Ladies and gentlemen, good afternoon and welcome to the University of Maryland Medical System. Let's talk about health community conversations. Today's conversation is one in a series where we discuss health topics that are important to our community. We host a different virtual community health conversation on the third Wednesday of every month at noon. I am Donna Jacobs, Senior Vice President at the University of Maryland Medical System, and I will be your moderator today. Our Let's Talk About Health series is designed to do a couple of things: provide tools and information that people can use to maintain or to improve their health and to improve the health of their families, and provide information that may be useful to patients when they are talking to their healthcare providers so that there's better and mutual understanding. To that end, parts of this conversation are framed in ways to assist patients and to assist people when engaging in a conversation with your healthcare providers by suggesting questions that you should ask. Our topic today is asthma, a condition that many in our communities suffer. And leading our conversation is Dr. Lisa Bell. Dr. Bell is a pediatric nurse practitioner at the University of Maryland Children's Hospital in downtown Baltimore. She cares regularly for children with asthma and allergies and provides asthma education to families and the community at large. Dr. Bell received her Master of Science in Nursing and her Doctor of Nursing Practice from the University of Maryland School of Nursing. She's a certified asthma educator, and she has led the work of the Breathmobile, which is a mobile asthma clinic for children in Baltimore City. In that our conversation today is meant to be such a conversation, please feel free to use the Q&A, the question and answer box, to type in questions that you may have as Dr. Bell is speaking. She has told us that she's happy to address as many of those questions as time will allow. Her slides will be available to you in a few days, so you don't have to write furiously. And I'll give you more information on that later. Dr. Bell, if you would.
Thank you so much, Donna, for having me here today. I think this is the perfect time for this conversation for two reasons. We're entering a particularly bad pollen season, so this is a time of year where people with asthma and allergies can really struggle. And of course, as we're all well aware, we're right in the middle of a pandemic of a respiratory illness. So as Donna mentioned, as we go through, we're going to use the Ask Me 3 program. And that's just a program that helps you have productive dialogue with your healthcare providers to get your questions answered so you can best understand your condition. So you'll see that as we go along. So we'll start with how big of a problem is asthma. So in the United States, about 25 million Americans suffer with asthma. It's a particular problem for children. It's one of the most common chronic conditions of childhood, with 7 million children affected in the United States. It's responsible for significant costs to the healthcare system when you consider emergency room trips for asthma, hospitalizations, outpatient visits for care. And when you consider things like loss of time from work for adults, or for parents who are caregivers of children with asthma when they have to miss school, the total cost for asthma in the United States is about $82 billion per year. We'll talk throughout this presentation. There's very effective treatments for asthma. It's very possible to control your asthma and prevent these things. But despite that, each year in America, over 3,500 people die from asthma. In Baltimore City, asthma is a particular problem. So Baltimore City consistently has among the highest asthma rates, the highest emergency department visits, and the highest hospitalization rates in the state, but also among the nation as a whole. The rate of emergency department visits for asthma in Baltimore City is 3 times higher than that of the state. And Baltimore City's average death rate from asthma is twice as high as Maryland as a whole. There's one particular group that's affected the most, and that's African American children. Just briefly, yes, thank you for going back. African American children are affected the very most. They have 4 times higher emergency room visits than white children, 3 times higher hospitalization rates, and an 8 times higher death rate. And when we talked about those asthma numbers, across the country, about 7 to 8% of people are affected by asthma. Here in Baltimore City, it's 20%. So what exactly is asthma? Most of you are probably aware it's a condition that affects the lungs, but specifically it affects the airways or the breathing tubes that are in the lungs. So in a person with asthma, their airways are very sensitive to what we call triggers. Triggers are things that irritate the lungs of a person with asthma. And these triggers wouldn't necessarily affect someone who doesn't have asthma. So you can see in this picture, on the left is a healthy airway, kind of blown up for you to see the inside of it, and on the right is an asthmatic airway. When a person with asthma is around a trigger, the muscles that wrap around the airways, and you can see those as those red kind of stripy things that wrap around the airways, those muscles constrict or tighten up. That's something called bronchospasm. So you can imagine if your airways are tightened, they're going to be harder to breathe through. Asthma also causes the inside of the airways to swell, and you can really see that on that right-hand side. And this is called inflammation. You can also see that yellow stuff on the inside is excess mucus. So you've got a combination of the swelling on the inside and the squeezing on the outside that causes asthma symptoms. And for patients or people who do not have asthma, the way a lot of times it's explained is if you imagine taking a straw and just trying to breathe through that straw. That's what it feels like for a person having an asthma attack. So I really want to highlight that idea of the inflammation or that swelling in the airway. That's the most important thing to understand about asthma, and it's the phenomenon upon which most of the treatment is centered. The key thing to know is you cannot always feel it, but the more swelling you have, the more sensitive your airways are to those triggers. And what I really want you to take from this picture is, again, on the left, you have a normal airway. It's nice and open, no swelling. On the right, just like in the prior picture, you have an airway having an asthma attack. You have that swelling. You can see the muscles are tightening around that airway. But in the middle, you have an asthmatic airway who's not having an active asthma attack. So even on a day that airway, that person's feeling pretty good, they're not coughing, they're not having trouble breathing, you see they still have some of that airway inflammation, again, making their airways more sensitive and more prone to an asthma attack. When we talk about triggers, you can think of them kind of in 2 broad categories. You have your allergens and then your irritants. So the allergies that can trigger asthma are, as I mentioned previously, right now we have a lot of pollen in the air. So the tree pollen basically is the first pollen to come out in the spring, so that starts early in March. The grass reaches its height in the summer. Weed pollens, like you've probably heard of ragweed, that's out in the summer and into the fall. So for kids, that's a big factor when they're starting school in September. The ragweed is really high at that point. And then you have outdoor mold that blows through the air, particularly in the fall months. Your indoor allergies include your furry pets like cats and dogs, pests like mice and roaches, dust, and of course indoor mold. And then your irritants would be smoke, of course, of any kind. So actively smoking, secondhand smoke. We even talk about thirdhand smoke when we're talking about children, and that's the smell of smoke on clothing. So if a parent is a smoker and they go to hug their child, just that smell on the clothing can be enough to trigger an asthma attack. Anything that smells strongly, perfumes, cleaning supplies. Change in weather is a big one. So as the seasons change, that can trigger asthma symptoms. Some patients are sensitive to cold air, while some are sensitive to hot air. Air pollution, and then of course a big one is colds and respiratory infections. And acid reflux can also trigger asthma. So those are the main triggers that we think about. So when a patient with asthma is triggered, the most common symptoms you see are you may see actual trouble breathing depending on how bad the attack is, shortness of breath. You may not see a full-on what you think of as an asthma attack. It may not be trouble breathing. You may see just a recurrent cough. So sometimes that can be a little tricky to diagnose and take a little bit longer to get treated because sometimes cough can be the only sign of asthma. A feeling of chest tightness. So for anyone who does not have asthma, it can be a feeling that something heavy is kind of pressing down on the center of your chest. It's an uncomfortable feeling. And then wheezing is that whistly sound. If you've ever heard a whistling sound when someone's breathing, that's just the sound that the air makes as it's going through those tightened and swollen airways. So different patients are different in their symptoms. So you may have someone with asthma who has all of these symptoms from time to time. They may have a mix, or again, they may have just what we call cough variant asthma, where it's just a repeated episode of cough. So who gets asthma? What are the risk factors? So some are genetic, and some are environmental. And it's a complicated process, but the thought is that asthma exists when you have an interplay between the two things. So generally, there's some environmental exposure in a predisposed individual that ends up causing the development of asthma. So those patient-related factors are, again, genetics or family history. So that's one of the big questions we'll ask if someone's having symptoms and not diagnosed yet is do you have a family history? So if one parent has asthma, that child is 3 times more likely to develop it. And if both parents have it, they're 6 times more likely. Also, if there's a history in that patient of other allergic diseases, so allergies and eczema are very related to asthma. So if a person has one of those things and they're having respiratory symptoms, you're heightened suspicion for asthma. Being born premature will increase your risk of asthma. Gender in kids, it's more common in boys than girls, but something happens around puberty where it becomes more common in females. Obesity predisposes to the development of asthma. And then in terms of the environment, allergen sensitization, so particularly at a young age, some of the most common ones associated with asthma are dust, cockroaches, and mold. So if you're around those things, you can become sensitized, become allergic, and that's linked with asthma. Certainly viral respiratory infections. So if you hear of kids getting RSV, that's a really bad respiratory infection that can predispose you to developing asthma. Being around tobacco smoke, again, the importance of smoke. That can be secondhand smoke or even in utero if the mother smokes, and then air pollution. Diagnosing asthma. So, a lot of patients will come in and say, can you test me for asthma? There are some tests that help you make the diagnosis, but it's really a diagnosis that's mostly based on a detailed history. So this is where your relationship with your healthcare provider really comes into play, and, kind of knowing what to tell them and what to look for. So they'll ask, again, do you have a family history of asthma? What are your symptoms? What are you experiencing? Are you experiencing those symptoms in response to certain triggers? And by the way, in addition to the symptoms being caused by those classic triggers that we talked about, asthma symptoms also often get worse in the middle of the night. So you can have someone who's completely fine during the day, and then at night they were waking up with chest symptoms. And I also didn't mention exercise. Sometimes I forget to say that because we want everyone to be exercising and keeping your heart and lungs healthy, but that can be a trigger if your asthma is poorly controlled as well. Physical exam, of course, your provider will listen to your lungs, but depending on when they're seeing you, you may or may not have symptoms at that time if you're not actively having an asthma attack or asthma symptoms. So you may look and sound totally fine when you see your provider. Lung function testing. So that top picture on that slide is a person performing a pulmonary function test or a lung function test. And basically, if you've never had that done before, you essentially take a really big breath in. And with asthma, you can breathe in, but it's hard to blow out through those tightened airways. So they'll have you blow as hard and as long as you can, and they'll measure how much and how fast you can blow out. And that can give us actual numbers for how tight your airways are and can help guide your treatment. And then allergy skin testing, of course, that wouldn't help diagnose with asthma, but it would help the whole picture. It would help diagnose on whether you have allergies or not. And that little white thing that you can see in that bottom left picture, that's an allergy skin test. It's just a little plastic thing with little prongs that stick up. It's not a needle or anything. It just touches your skin. And then you'll see in the picture on the right, whatever little extract that you're actually allergic to, you'll get a little hive, and we can tell you within 15 minutes what exactly are your allergic triggers. So here's an example of using the Ask Me 3 program. So this would be a case of a person who maybe is not yet diagnosed with asthma. So a problem could be, I'm noticing that every time I catch a cold, it goes straight to my chest. I get a cough and this feeling that it's hard to breathe. The cough seems to linger on for a couple of weeks. So I'm missing work more than I'd like to. So sometimes with asthma, symptoms may only be with colds. You may be able to exercise just fine and do well in between, but when you get a cold, you get that feeling where it goes to your chest and lingers. As the cold goes away, that cough continues. So what is our problem? Chest symptoms triggered by respiratory infections could be due to asthma. What do I need to do? You'd want to track your symptoms. It's always helpful to keep a log because, again, asthma is a diagnosis of history and repeated episodes of the same pattern. So the first time you get a cold and you get a bad cough, they're not going to call it asthma, but you have a repeated history of that. So track your symptoms. Determine whether or not you have a family history of asthma. A lung function test might provide more information. And a provider would likely give you, especially if there was a family history or it seemed like asthma, they'd likely give you an inhaler to try the next time you're sick and see if it works. And why is it important for me to do this? Untreated asthma is dangerous. Not only do you want to just be able to feel better and manage your colds better the next time you get sick, but as we said in the beginning, you can die from an asthma attack. And I want to mention that even people with mild asthma can die from asthma attacks. It's not just those ones with severe asthma and repeated hospitalizations. Anyone is at risk. So we'll talk a little bit about the medications. So the one people are probably the most familiar with is your quick relief medicine or your rescue medicine. Some people call it their emergency medicine. I don't like to call it that because I don't want people to wait till it's a full emergency. We want people to treat their symptoms before they get to that point. But quick relief or rescue medicines, they're used on an as-needed basis when you're feeling your asthma. So when you're coughing, when you're wheezing, when your chest is tight. They work fast. So typically they're taken by inhaler, 2 puffs every 4 to 6 hours when you need it. And they work within 10 to 15 minutes. But what I want to highlight here is that they're a quick fix. They only last about 4 hours, and they do nothing to prevent future symptoms. So what they do is they work on those muscles that are tightening and squeezing around the breathing tubes. So they work quickly, they relax those airways, but the key thing to highlight here is they do nothing for the swelling. So the most common one you see is albuterol, and I just like to put this picture up here because it can be confusing because different brands and different companies make them in different colors. and there's generic ones now. But for the most part, I generally see either the red one or the bluish gray one, occasionally the yellow one, but it's all the same and it's all taken the same way. And so we talk a lot about how to use your inhaler device. So it's important, the first piece of the puzzle is having the right medication, but if you're not taking it correctly, it's not going to be able to work. So we have everyone use their inhaler with something called a spacer device, which you can see pictured there. Some people think that's just for kids because they don't know how to use their inhaler correctly, but we want everyone using an inhaler to use a spacer. The idea being that the medication squirts out of an inhaler at about 60 miles per hour. So the way to kind of explain it is if you think of your mouth and it has to go down to your lungs, it has to make basically a 90-degree turn. So if you think of a car that's driving, if it's going 60 miles per hour and it comes to a sharp turn, it's going to crash. So the same thing happens with an inhaler. When you put it directly in your mouth, it's going so fast, most of it crashes on the back of your throat and deposits there and does not get down into your airways where it needs to go to do its job. The spacer essentially slows down that medication so it can nicely make that turn and go down, just as if that car slowed down and made the turn. So for adults or older children, we use a spacer with just a mouthpiece on the end, and the young children, we put a mask on the end. But basically, you always want to shake your inhaler. In an inhaler, there's medication as well as the propellant that makes it come out, so you want to make sure it's nice and mixed. You want to blow out, you want to exhale before you put it in your mouth, so you're ready to take a deep breath in. So you blow out, place it in your mouth with your lips sealed around the mouthpiece. You do one puff at a time, so rather than doing puff, puff, you won't get both puffs that way. You want to do one puff, and you just take a slow, deep breath with it in your mouth and hold your breath for 10 seconds. If you have a spacer and you hear this, if you hear that whistle sound, that's a warning that you're breathing in too fast. So you actually don't want to hear that whistle. Some people think you want to make it whistle. You don't want to hear that. So you can, if you breathe nice and slow, you won't hear a thing. After your first puff, you want to try to wait 1 minute before you do your second puff, and you just repeat. And then for young children, we make it a little easy for them by putting a mask on the end, and you just shake it, and you place the mask over their nose and their mouth so it's sealed on their face, and you do one puff, and you just have them breathe in and out 5 to 6 times, so they don't have to do anything special, they don't have to deep breathe, they don't have to hold their breath, just nice and easy breaths in and out. Care of your inhaler, once a week, what you want to do, so if you ever looked inside of an inhaler in the mouthpiece, there's a little tiny hole where the medicine shoots out. That can become kind of clogged if it's not used in a while or just after repeated use. So once a week, you're supposed to pull the medicine canister out, and then you're just left with the plastic, and just rinse water through it for 30 seconds, and that clears that hole. So you get your full dose when you go to use it the next time. If you haven't used your inhaler in a couple weeks, if you're someone who doesn't use it very often, which is what we want, or if it's the very first time you're using a new inhaler, you just want to waste 4 puffs into the air. That's what we call priming it. That primes it through and gets you ready to take that full first dose. And once a week, as far as your spacer, you just want to wash it with dish soap and warm water and let it air dry. So asthma is a chronic condition. There is no cure for it. But what I really want you to take away from this, whether it's yourself or a child with asthma, is it can be controlled. We don't want it to just be normal for you that you're taking your child to the emergency room a couple times a year, or yourself. That can be prevented. And the way we do that is, well, it's a combination of things. We're going to talk after the medication section briefly about managing your triggers. So it's a combination of knowing what to avoid and then what we call controller medications. So everybody with asthma has their rescue inhaler. But people with more persistent, more frequent symptoms, which we'll talk about, have a second type of inhaler that's called a controller. And this is the only way to prevent asthma symptoms. These are slow-acting inhalers where the rescue medicine works within a few minutes. These work over time. They're slow-acting, and so you have to take them every day. Even on the days you feel well, you're not having any problems with your asthma, you still have to take your controller. And if you remember back in the beginning, I had those 3 airways, the normal airway, the one having an asthma attack, and then we had that one in the middle who had that inflammation, but they didn't feel it. That's what this is about. These medicines treat that swelling in the airways. If you take it every day, it prevents that swelling from returning and keeps your airways, again, less twitchy and less responsive to those triggers. I think I like to explain it like a person who has high blood pressure, because people are pretty familiar with that. You don't feel your high blood pressure every day, but you know you have to take your pill every day. Asthma is the same way. So there's lots of different controllers. But the main component is inhaled corticosteroids. So when you get really sick and you end up in the emergency room or hospital or your primary care provider's office with an asthma attack, they give you steroid medicine, but it's the kind you take by mouth. It's pills or liquid for kids. That's the kind of steroid we don't like people to need a lot of. That can have a lot of side effects associated with it over time, especially patients with really bad asthma who need it a lot. But putting that type of medication into an inhaler makes it so it doesn't have those side effects. You're not swallowing it and absorbing it throughout your body. You're just inhaling it so it can act locally in the lungs where it needs to work. So these are just some of the most common ones. And if you go to the next slide, there's some more. So you have just plain steroids. And then you have combination medications for, they include a steroid component and then a long-acting form of that rescue medicine. So that, for people who have more significant asthma, a combination medicine will have one medicine for the swelling and one to keep the muscles relaxed. And there's all different types. You can see some of them are regular inhalers like you think of, where you use them with a spacer. Particularly for adults, some of them are powder inhalers that you take a little differently. They're all slightly different, but I think the most important thing to take away is, ask your provider to demonstrate for you exactly how you use any particular inhaler that you're prescribed. Ask the pharmacist. Any of them have, the companies have websites where they'll all have videos that show you exactly how to take it. So these are the really key questions that you want to ask yourself and that your provider should be asking you. And if they're not, that's why I want you to know these things to look for. So, does your asthma keep you from doing certain things? It's not okay with us for you to have your child sitting out of gym class because they have asthma, or not doing sports that they want to do, or not exercising for yourself. Do you use your rescue inhaler to get relief from symptoms more than 2 times a week? Do you wake up with coughing or any trouble breathing more than twice in a month? So that's not a lot. So if you're waking up with asthma symptoms more than twice in a month, you want to talk to your provider. Have you had to fill more than 2 of your rescue inhalers in the prior year? Or have you had to take steroids by mouth, typically prednisone or Prelone for kids? It could be Decadron. For an attack more than twice in the past year. So even if this comes into play a lot with the people who get triggered by colds. Again, even if they're fine in between their colds, if you're needing treatment with a steroid more than twice in the prior year, you want to talk to your provider. If you answer yes to any one of these questions, your asthma is what we call not well controlled. So once again, we're going to use the Ask Me 3. So whereas the prior example was a person who's not yet diagnosed with asthma, this person is. So they say, I notice that I'm waking up at night with a cough and feeling like my chest is tight. It's really been worse since the spring began, and I'm having to use my rescue inhaler more often. So what is our problem? Again, waking up at night from asthma is a sign of poor asthma control. And once again, it shouldn't be more than twice in a month. What do I need to do? So again, a lung function test might provide more information and see if your medications need to be adjusted. If you're not on a controller medication, this would be time to talk to your provider about getting one. The patient mentions it's worse since the spring season began. That would trigger you to think about potentially a pollen allergy. So maybe allergy testing would be in order, or just trying an allergy medication, because the better you can control those allergies, the better it will prevent it from triggering the asthma. And why is it important for me to do this? Again, poorly controlled asthma puts you at risk of an asthma attack, could be fatal. And another thing I didn't mention previously, not only do we worry about asthma attacks, but poorly controlled asthma over time can change the inside of your lungs. It can change your airways and cause permanent damage, and become to the point where your lungs are not as responsive to the treatments that we have. When do I seek emergency care? So if you're ever having symptoms and the rescue inhaler is either not working, or maybe it works, but it's not lasting you 4 hours. So certainly when you go to a hospital point of care, you're going to be given that medication more often than every 4 hours. But if you are at home, it is not safe to be doing that. You really need to get somewhere and be seen quickly. Certainly if your symptoms are severe. So if the wheezing is severe, the tightness is severe, signs that you can see in your children or yourself, if you ever see the nose flaring when they're breathing, or pulling in kind of right here at the neck or in the ribs, those are signs that your body's having to use extra muscles to pull in that air. That's emergency time. If someone ever can't speak in a full sentence, certainly if they're out of breath or their lips or their fingernails are turning blue, don't wait, call 911. And again, almost all deaths from asthma are entirely preventable. So don't hesitate to call 911. Just briefly, like I said, part of the puzzle is having the right medications, and the other part is knowing your triggers and minimizing them as best you can. So just to kind of go through quickly, smoking, again, do not smoke around your kids. No amount is safe. That goes for any kind of smoke. And again, we talked about that third-hand smoke as well. 1-800-QUIT-NOW is a wonderful resource for smokers who are interested in quitting. They can counsel you over the phone and send you patches and things. Dust mites. So a lot of people are allergic to dust. So those patients, we have them get what we call dust mite covers or allergy covers for their mattress and pillow. So basically dust mites live in your mattress and pillow, anything that's fluffy, and those encasings prevent them from getting through and crawling on you at night. Washing your sheets in hot water will kill the dust mites. Minimizing sleeping with stuffed animals, that can be a hard one. Minimizing carpet if you can, but if you have carpet, vacuuming it frequently. Avoiding humidifiers. A lot of people ask about that. Humidifiers actually, they actually cause dust mites to multiply, and they can actually affect mold levels as well. Pests like roaches and mice. So of course, traps. Always being conscious of sealing your food in containers, not leaving food out, disposing of trash properly, sealing any cracks where they may be getting in. Furry pets. We tell our patients who have a pet and don't necessarily want to find a new home for the pet to start by keeping that pet out of the affected person's bedroom. Even when they're not in there, just keeping the door shut so they can't get in there and spread the allergen in that room. Washing them weekly. Again, minimizing carpet keeps it from sticking in the carpet and staying around all the time. Pollen, using air conditioning when you can. When you open those windows on a beautiful day, the pollen comes in. Showering or at least washing your face and hands after you've been outside can help. Pollen is the worst in the early morning and at dusk and on windy days, so avoiding that when possible. And then, of course, mold, so just making sure you don't have any leaks in the home. Again, avoiding humidifiers, using your fans in the bathroom. I want to just let you know about this awesome resource. As we said in the beginning, I've been the nurse practitioner on the University of Maryland Children's Hospital Breathmobile for the past 13 years. And for any of you that have children with asthma, know children with asthma, this is an awesome resource. It's a mobile clinic, that's a picture of it, and we actually go out into the community to schools in Baltimore, and provide care for the kids with asthma right there at their school. So it's a specialty asthma clinic that goes out into the community. So it's no different than if you would bring your child to a specialty appointment. We have the lung function testing, we have the allergy testing, and we'll work with you and your child to help get their asthma under control. Your child does not have to be a student at our schools that we service. Anybody can come anywhere, and right now we're doing a lot of telemedicine. That's been, I think, one good thing that's come out of this pandemic is, us starting telemedicine. So even for kids in Baltimore who can't get to us, we can do telemedicine visits. And speaking of the pandemic, I wanted to mention earlier, so the CDC does list people with moderate to severe asthma as being particularly high risk for hospitalization from COVID. So what we're telling our patients with any level of asthma, even mild, is if you're on a controller medicine, keep it up. Typically when someone starts a daily medication, they may be able to come down or stop it if they've been well controlled for 6 months or so, depending on the patient, but we're not stopping anybody's, we're keeping it going. So just making sure more than ever that your asthma is controlled, and if it's not, speak to your provider. That's the main thing that we're saying. And vaccines as soon as you can. So here's just a more complete list of a few resources. So again, if you have a child with asthma, there's the Breathmobile information. You can call that number. We can do an in-person or telemedicine appointment for any child 2 to 18. It is free. We don't even take your insurance. The Asthma and Allergy Foundation of America, the Allergy and Asthma Network, and the American Lung Association all have wonderful patient resources on their websites. And I mentioned the Maryland Quit line for any smokers out there who are interested in quitting, 1-800-QUIT-NOW.
Dr. Bell, thank you so much for that incredible presentation. It was very clear and certainly very informative. And I learned a lot as well, particularly about the spacers. I would tell you, I believe I've seen hundreds of people with their asthma pump, as everybody affectionately calls it, and I don't ever remember seeing a spacer. I've got to say that. And there are questions here for you with regard to that. I'll just give you both. One is, how can you obtain a spacer for the inhaler? And the other question came in early, which is, I use a ProAir RespiClick. Should I be using a spacer with this as there's no aerosol?
Great question. So I didn't put that specifically in here because I see that so rarely. I don't know if they use it very often in adults. Like I said, I'm more pediatric, but ProAir RespiClick does not need a spacer. And I should have mentioned when we talk about the controllers, and I mentioned a lot of the ones particularly for adults are powder inhalers, you do not need a spacer with them. So that's a great question. You do not need a spacer with that. As far as your regular inhalers go that you press, how to obtain a spacer. So they're covered by insurance. So typically if you ask your provider, they can write a prescription. Be careful with it. Some of the insurances will only cover one per year, which sometimes can get dicey for a child because we want them to have one in school as well. For our children who would come to see us at University of Maryland, either on the Breathmobile or in one of our specialty clinics, the pediatric pulmonary or allergy clinic, we physically have the spacers there to hand you. I'm not sure what adult clinics do. I would think that they would as well. And that gives us the opportunity right there to have you learn how to do it and demonstrate, and we can correct any issues.
And so just to be clear, you should ask your provider to prescribe a spacer to you.
Correct. Correct. And like you mentioned, Donna, unfortunately with the adults, a lot of times you will have to ask.
Right, sure. So other questions, you spoke about the numbers of triggers that exist. And there's a question about stress. Can stress in and of itself be a trigger for asthma?
It absolutely can, absolutely. It's sad to see that in our children, but it does happen. And you know, the other thing that it can trigger, I feel like stress just affects so much in your body, but a lot of our kids, as I mentioned, also have eczema. So I always think of this one girl, she would get stressed when she would come into the clinic for appointments, and she would literally walk in the door and you could just see before your eyes her eczema would start to pop up. So yes, it can. So those patients, we try to work with them on kind of, it can be hard to recognize too sometimes what is stress actually triggering your asthma and what is anxiety, because that can cause some of those symptoms as well. So we try and work with our patients on that, doing some deep, slow breathing exercises.
A few more related questions on triggers and what causes what. There's a question here, does sleep apnea affect asthma?
Yes. So sleep apnea affects a lot of things. We worry very much about blood pressure and cardiac issues, but sleep apnea can make asthma worse. So a lot of times, once the sleep apnea is treated, the asthma starts to fall into play. Being a healthy weight, too, especially, in kids, we see a lot of sleep apnea because their tonsils are so big, but we also see it from kids who are overweight or obese. So, people will ask, well, what can I do? What foods should I not eat with asthma? What can I do as far as that goes? There's no particular thing other than having a healthy diet, healthy lifestyle, and the better you can maintain a healthy weight, the better it is for both conditions, asthma and sleep apnea.
And weight can affect each of those independently, sleep apnea singularly and asthma singularly, correct?
Absolutely, yes.
Yeah. What is thought to be the reason for the high incidence of asthma in Baltimore City? Those numbers that you gave were startling.
Right. So part of it is, again, that sort of genetic piece. So you see it more in African Americans. So you have that component that you can't do anything about. And then the other part, when you think of the environment, so any urban areas have more of those triggers. As I said, I work out at the schools, and I can tell you even in the schools, you walk in and you can see roaches and mice in some of them. They say over 90% of homes in Baltimore City have detectable mouse allergen in them. So the allergen from mice is in their urine. So even if you're not seeing the mice physically, that allergen is often there. So, and certainly there's more air pollution in inner city type environments. So it's a combination of those things.
Lots of questions here about triggers. Can supplements or herbal medicine be a trigger?
Ooh, so I don't encounter that as much in kids. I think the answer to that would be with any herbal medication or supplement, you always want to, a lot of them are not FDA approved or regulated. So that's something that you'd always want to talk over with your provider. I can't speak to any specific ones, but it's definitely something to always consider in any of your healthcare and interactions with medications and stuff.
All right, and I'm going to assume that this is a type of, you said don't use the word emergency medicine, but so can Brio, I may say this wrong, Brio ellipta 225 cause symptoms of panic attack? And if so, what do you do about it?
I would definitely not say that would be a common side effect. Brio is an adult medication, and it's a combination. It's one of those combination ones where it has an inhaled steroid and a long-acting form of that rescue inhaler, albuterol, that lasts 12 hours. So in theory, what I'm thinking is the inhaled steroid, you're not going to have any immediate effects from. But that long-acting form of the rescue medicine, any form of rescue medicine, it affects the same receptors in your lungs to do its job that are also found in your heart. So I would be curious if that person has a lot of fast heartbeat when they take their rescue medicine, because we do see that. That's kind of an unavoidable consequence with the rescue medicines. So that's kind of how I can tie that in. So anything with a side effect like that, I would absolutely speak to your provider. And as you saw on those slides, there's tons of different options for controller medicines. Some of it is going to depend on what your insurance covers, quite honestly, but then the other part is just some people do better on one than the other. So they might be an equivalent medicine, but a different one might help another person more. So I would definitely talk to your provider, because there are certainly other options for you.
Two questions related to the medicines. One is about the controller medicines, and the question is, did I understand that everyone should be on some sort of controller medicine? That's the first question. And then the other one is, Are there now or soon to be alternatives to steroid medicines for long-term control of asthma?
Okay, so I apologize if that wasn't clear. Not every single person with asthma needs to be on a controller. The new guidelines just came out, so there's national asthma guidelines and there's global asthma guidelines. The national ones, it was a big deal because they were just updated for the first time since 2007, and the global ones come out every year. They're starting to get more quick to recommend a controller, but a general rule of thumb, that slide, and I know Donna said you'll get a copy of these slides, the one with the questions to consider. If you are not able to do the activities you want to do, if you are using your rescue inhaler more than twice a week, if you are waking at night more than twice a month, or if you are having flare-ups or attacks that require you to take oral steroids more than twice in a year, that's who needs to be on a controller. Some people are on controllers just seasonally, depending on them. So, you know, some of our kids who really struggle just when they get cold, some of them just go on a daily medicine for fall and winter or during the school season. People who are just really primarily triggered by pollen might only be on it for the spring and summer season. So again, it's that asthma is, I think, really important to have that relationship with your provider, because not every asthmatic is the same. So they've really got to get to know you. You've got to be able to talk to them and know, again, what things to tell them so they can tailor your treatment. Are there medications for controllers in the works that are not steroids? There is one, some of you may have heard of Singulair or Montelukast. That's a once-a-day pill. For kids, it's chewable. For adults, it's just a little swallow pill. That's not a steroid, that's a controller, but it's either for someone with super mild asthma, because it's not strong. So either you have very mild asthma and that's what you take, or more commonly it's something we add on to inhaled steroid when someone's not doing well just on the steroid by itself. In terms of other treatments, the only other thing that's really exists right now are, and this would be a really high-level treatment for someone with either moderate or severe asthma, is what they call biologic medicines. So again, that idea that not everybody with asthma is the same, and so in your body, there's lots of different types of cells that cause that inflammation, and what's causing it in one person may be different than what's causing it in another. So what specialists can do now is draw your blood and see exactly what cells are playing a role in your asthma. And then now they have injectable medications that actually kind of bind those cells and make them inactive. But that wouldn't be in replacing the inhaled steroids. That's something certainly to go beyond a regular injection is not something you want to do unless you've kind of exhausted everything else. So again, it's more of an add-on thing. But again, we don't really worry about side effects from the inhaled steroids. The only side effect that we do really speak about is it can cause thrush in your mouth, which is kind of that white little like yeast infection kind of thing. You see it in babies sometimes. So it's a good practice. After you take your daily inhaler, no matter which one it is, you should brush your teeth afterwards. And the spacer cuts down on that as well as an inhaler. So I tell a lot of my families too, just keep your inhaler by your toothbrush, and not only will you remember to brush your teeth, but hopefully you brush your teeth every day so you'll remember your inhaler.
There are a few questions coming in. I'm going to try to group them if I can. You did speak earlier about tests for asthma, and maybe this person who asked this question came in a little bit late, so that'll be available on the slides, and I'll explain later how people can find that. But several people said, besides your regular provider, your general practitioner, who do you go to help treat asthma? What sort of doctor do you look for?
So there would be two main ones, either a pulmonologist, which is a doctor that specializes in any lung conditions, or an allergist. Both of them treat asthma. I would say if you are a person who really feels like you have that allergic type asthma where allergies really trigger it, you have a history of, seasonal allergies, you have eczema, that would lean you more towards seeing an allergist. Or if you're just wondering if you have allergies and you want an allergy test to really get a full understanding of your triggers, In kids, we most commonly see allergic asthma. In adults, it's not always so. So if you really have no symptoms of allergies, no family history of significant allergies, a pulmonologist could treat you as well.
You got to thank you for the great response on the meds question, by the way.
Oh, thank you.
Several questions related to air conditioning, ceiling fans, and temperature, 3. So you spoke about using the air conditioner as opposed to keeping the windows open, clearly. What about a ceiling fan? And then some questions about the cold and the warmth. I know you did say that cold or warm could be a trigger. Somebody says, is it better for me to try to sleep in the cold? And then a related question, sorry to group all these together, but we're running out of time. A related question is, what do you do when someone's had an asthma attack, you're waiting for 911? If it's warm inside, I've always heard that you try to get them outside to the cooler air, but if that's a trigger, we're in a conundrum. What do we do?
Right. So this is kind of where it goes back to knowing yourself, and not everyone is the same. So I have patients who, the parents will be so upset. They're like, oh my gosh, he can only sleep if he has the window open and the cold air is blowing on him. And then I have the opposite where it has to be hot in the house. So it really depends on the person. I feel like more commonly it's cold that triggers asthma, but it could go either way. So a lot of families feel like they kind of have to just find that right temperature. Ceiling fans, I would say, the only thing I could think of that mattering would be like if it was real dusty on the ceiling fan, and then the dust is blowing around. So as long as you're dusting it, unless that particular person has an issue with the I don't know how to say the air from the fan, the air. And unless that particular person has an issue with the air from the fan, it's not something that we generally caution people about. The main thing we talk about is using air conditioning instead of opening your windows. My son has terrible allergies, and we never open the windows in this house. So I hope that answered the question.
I think it did. So a few more questions, and then we're going to have to wrap this up in just a couple of minutes. Someone said, my daughter left home and went to college, and her asthma attacks abated, which suggests that there may be some irritants in the house. And one says, what about the presence of pets in the home? My doctor never advised me. We had an African gray parrot that caused terrible attacks. Pets in the home is something you've addressed a little bit.
Yeah. So again, just depends on the person. There's lots of studies about like little kids. Does having a pet help or hurt their chance of developing asthma? And it's all mixed. So as far as the development of asthma, there's nothing that we can concretely say, but certainly if you have a pet, that could be a factor. And we tell people, if we allergy test someone and we say, oh, you're allergic to cats and dust and pollen, and they'll say, well, can I get a dog? Your allergies can always change. Asthma can change. So we always say, you have that tendency to be allergic. So if you get a dog, just know that you run the risk you could become allergic to the dog.
Prometine mist, what do you say about that as a controller for asthma?
So that is not something that we use. Do they still make that?
Well, somebody said, is it still considered a poor choice? So
yes. So really the treatment is, you can still get it. You can get it at Target. Yes. You don't want to be, when it's coming to controller medications, first of all, you don't want to be treating yourself and going over the counter and buying something. You really, asthma is as serious as it can be. You want to be under a provider's care. It's a bronchodilator. But you should really have your prescription for an albuterol inhaler, so we really would steer away from that. Another question we get a lot, again, about over-the-counter medicines is, should I give my child cough medicine? So cough medicine, certainly I think we all take some form of, cough and cold medicine when we have a cold, but the idea is if you take a cough suppressant, that's just telling your brain not to cough. It's suppressing that cough reflex. So in a person who has asthma, you're not treating the actual cause of your cough if that's all you're doing. So we really want to focus in an asthmatic, even if you have a cold, make sure you're using your inhaler so you can treat the actual tightening and swelling in your lungs.
I'm going to combine two again. My spring allergies have been terrible this year. I heard people say that last year too, the last few years have been bad. Are there any new antihistamines that can help with spring or tree allergies? That's one question. And the other one is, should asthmatics just wear a mask all the time?
I have asthma. My kids have asthma. I wouldn't want them to do that, but no. So the best allergy medicines are kind of like I mentioned with asthma medicines, and probably even more so. A different person can respond better to a different one. Allergy medicines really are all over the counter. There's really not many prescription strength, quote unquote, allergy medicines. So your main ones you see are Claritin, Zyrtec, Allegra, and then there's Xyzal, that's with an X, X-Y-Z-A-L. I would just say from experience, 9 times out of 10, Claritin is the least effective. So I would try any of the others, Zyrtec, Allegra, or Xyzal. Get generic, save yourself money. And if that's not enough, that's when you want to think about adding in a nasal spray, like a Flonase or a Nasacort. That's going to work with the inflammation up here. So where you may have your controller for the inflammation down here, the nose sprays really do the same job up here. And what we tell people is it's all connected. So if you have allergies that are a significant issue, the better you can control the swelling up here, the more you keep it from going down to your airways. And so we say, so don't wear a mask all the time. Enjoy life, but you know, like we said, take your allergy medicine.
After COVID, don't
right. Hopefully we can say that one day. But yeah, take your allergy pill in the morning. This time of year, sometimes people do better just to take it every day rather than constantly treating symptoms when they're happening. Just take it every morning, and again, kind of wash it off when you come inside, kind of thing.
Dr. Bell, let me say thank you to you, and as one of the listeners has said, this is an absolutely great presentation. And for those of you who may have come in late or simply want to see this once again, a recording of this webinar will be posted in about 48 hours on our site at ums.org/Let's Talk. There was a question that came in near the end here about night congestion, which was addressed a bit, and you can see that. As well, you can look at any of the prior presentations we have done, and those topics are there with a wide range from COVID vaccines to heart disease to advanced directives, last month diabetes, etc. So you can look at any of those at the site. We invite you to do so, and the slides will be there as well for you. We look forward to you coming back each month. Next month, we're talking about stroke prevention, and we're going to run through June with skin cancer. We will be off in July and August, and then we'll start with an entirely new series after the summer. So thank you all for joining today, and Dr. Bell, thank you ever so much for sharing as you've done with us today. We really appreciate it. This was excellent.
Thank you.